Much, and thank you for asking me to talk. A very esteemed faculty. It's an honour to be asked to join. Can you see my screen at the moment?
No, Larry, we cannot. We cannot.
I'm pressing the share screen button, but nothing's happening. Oh, hang on a sec. Try that one.
Yes, now we are sharing.
Okay, lovely. Thank you. So why is this important? Well, as you know, cataract is the commonest surgical procedure in the world, roughly 8 million cases worldwide a year. And if the incidence of posterior capsule rupture and vitreous loss is somewhere between 1 and 2% for experienced surgeons, this is almost a pandemic. It's about 160,000 cases a year with an increased risk of sight-threatening complications. So this is a workload that we don't need, and certainly that the patients don't want. I'm going to talk a little bit about the risks. They are, as you all know, I'm sure, suprachoroidal hemorrhage, cystoid macular edema, endophthalmitis, glaucoma, and retinal detachment. And thinking of retinal detachment, the incidence of retinal detachment, the increased risk is about 40 times higher after vitreous loss during cataract surgery. So it's a significant increase in the risk. I'm going to talk very briefly about prevention. Two things have made a huge difference in my unit in England. One is risk stratification, and what we do for that is we use the information gained from the National Cataract Data Set, and John Sparrow in Bristol, Professor Sparrow, did a lot of work analysing that data set, and these are the risk factors that are proven to cause an increased risk of posterior capsule rupture vitreous loss. So even an inability to lie flat gives you a small increased adjusted odds ratio. Right down to the bottom there, you'll see trainee surgeons. It's nearly 4 times as common for a trainee surgeon to lose vitreous. So using these factors, we constructed a scoring form, and whenever we list a patient for cataract surgery, we have the factors down here, and the scores are added up, and if the score is 3 or more, then that patient is allocated to a senior surgeon with experience to make sure they do the case. We looked at the about 27,000 cataract operations performed across two time periods, one 3 years before we introduced this form and 3 years after, and we found that we had a statistically significant drop in the vitreous loss rate of 20% after the introduction of the risk scoring form. And this was due mainly to the trainee surgeons. This was their incidence of cataract surgical posterior capsule rupture rate dropped dramatically simply because they were being given the appropriate cases now, and the more complex cases were being given to more experienced surgeons. So that worked extremely well. The second thing was the introduction of the silicon-tipped IA probe. When we looked at our vitreous loss data, we found that the main 2 times that we were losing vitreous during cataract surgery were once we had pieces, the Phaco2 segment, if you like, and irrigation aspiration. They were the 2 commonest times. Once we introduced the silicon-tipped IA, that's now reduced to 0. We no longer lose vitreous during irrigation aspiration at all. And here's just a quick video showing why that is. This is actually a case of a lens exchange with severe posterior capsular opacification. And if I move this on quite a lot until the IA starts, you'll see that the silicon tip is extremely gentle, and even if it catches the capsule, which you'll see in a moment, it just wrinkles it and then lets go again. So it's a very safe procedure. It's a nice coaxial instrument and extremely gentle on the capsule. There are 1 or 2 reported cases in the literature of capsules breaking with this probe, but it's always been due to a faulty machining where the metal inside comes into contact with the capsule. So with an intact probe, you never break the capsule anymore with these. What if you do break it? Well, we all know that happens, and just really to cement in your minds what the vitreous looks like, this is a human eye in which orange paint has been injected. This is Jan Verst who did this, and I want you to keep this image in your mind. This is the vitreous body, which you know, is not just a single strand of vitreous. It's a huge complex mass of tissue in the eye, all interconnected. And keep that in your mind, vitreous loss. This slide I borrowed from my good friend Brian Little. This is his 8-point plan for managing vitreous loss. Obviously, we talked a bit about prevention. It's a big topic. Very important to have a very short denial phase. Don't pretend it hasn't happened. Don't panic, because your performance goes right down if you panic. There's a very good study showing that a panicking surgeon does less well. And the main thing really is this: don't pull on the vitreous, because if you pull on the vitreous, remember the orange paint picture, you pull on the vitreous base, you'll open up post-oral breaks and you'll get a retinal detachment. So how do you avoid it? Well, you visualize it, and we'll talk about that. Then you remove it and obviously follow the patient up. What you don't do, you'll see this surgeon here has firstly, I think, made the mistake of leaving the second instrument in the eye during the last stages of phaco. This destabilizes the anterior chamber. You get lots of eddy currents. And if you watch now, he's chasing the pieces, and there you'll see these striations. He's just caught the posterior capsule. It happens in the blink of an eye. And now is what Dr. Kapoor did very elegantly in the previous surgical videos. You stabilize the anterior chamber by injecting a viscoelastic, because at the moment you can save this situation by just rounding out this posterior capsular tear, making a posterior capsulorhexis, putting an implant in, and you're home and dry. But watch what this surgeon does. They panic a bit, take the instruments out, and then bang, posterior hyaloid or the anterior hyaloid ruptures, posterior capsule break extends, and you've now got vitreous in the anterior segment and a 40 times increased risk of retinal detachment. So if you see it happen, you've got to maintain the anterior chamber stability to prevent this happening, and then identify the vitreous and then remove it with a vitrector. Now, we used to do a lot of this, and I would urge you never to do this again. This is a Wexel sponge and it's pulling on the vitreous, and this act is enough to open a break in the post-oral retina and cause a retinal detachment. And in the old days, some manuals still make them, but the eye is open, the dynamics are all wrong, there's no closed chamber, it's a very uncontrolled situation. So I would urge you to avoid that. The other thing I would urge you to do is to always think of using triamcinolone, and this video is really just to demonstrate that. This is a patient with a lens coloboma, and they're having cataract surgery, and you'll see that once there's a capsule tension ring placed, and once the cataract is out, which is at this point here, everything looks lovely. But the surgeon decides to put some triamcinolone in just to check. And once you put it in and then wash it out, anything that's left is vitreous. So that huge wodge of vitreous you can see in the anterior chamber was completely unnoticed before the triamcinolone went in. And that demonstrates beautifully the purposeful use of triamcinolone to make sure you visualize the vitreous. This surgery then is quite an old video. The vitrector used to remove it. It's nowadays reduced by a manual. Then the IA can be done safely, and then the surgeon checks again, and there's more vitreous in the anterior segment. Now, if you put an implant in at this stage, these strands of vitreous will wrap around the legs of the implant and again cause a post-oral retinal break. So more vitrectomy, and then the lens will go in very safely and center very nicely because there's no vitreous in the way. So triamcinolone is essential to visualize the vitreous. There are surgeons who think they can see it, and believe you me, they can't. You're all looking through your vitreous at the moment. It's invisible. So it is important to visualize it using an adjunct. It is, in the UK, we most often use Kenalog, which is a preserved version, but you can buy intrasenol, triessence, and trivirus. These are preservative-free, and use them in the same way. I usually dilute it 5:1 with one part triamcinolone to 5 parts BSS, inject it into the eye, and it sticks to the vitreous. And the other important thing is doing an anterior vitrectomy is that in the old days when the eye was open, as I showed previously, the danger was that if you put the fluid into the eye with a coaxial vitrector, you would wash a whole lot more vitreous out. Nowadays, using a closed eye and a closed anterior segment, you can leave the bottle height where it is. It doesn't need to come down because there is actually no flow until you get a change in pressure. And you don't get a change in pressure until you start aspirating. So leave the bottle height high, set the vitrector to cut aspirate. That means when you put your foot on the pedal, the first thing that happens is the vitrector starts to cut, and then it starts to aspirate. If you have it the other way around, all you're doing is sucking on the vitreous and pulling it into the vitrector, and you will again open up post-oral breaks. Have the cut rate as high as it will go. Modern machines, 7,000-8,000 cuts a minute, just put it up to maximum. And vacuum 250, 300 is usually adequate. And then you can actually, if you're doing a vitrectomy and you have bits of lens mass there, you can actually switch the cutter off and use the vitrector to do irrigation aspiration to take out the residual soft lens matter, and then again switch it back on to do more vitrectomy if you need to. So this in summary is what it looks like. You can use the main wound to inject the triamcinolone, but don't use the main wound for the vitrector. Make 2 side ports and put the unsleeved vitrector through one and the irrigation through the other. You've then got a closed chamber. It's a very controlled pressure system, and you can remove vitreous. You can see it easily. You can remove it under a controlled fashion and make sure you're not exerting any antero-posterior traction with your vitrector. We all do this, once or twice a year if we're lucky, if we have a low vitreous loss rate, the trainees more commonly. So how do you practice this? We all know that you don't get good at anything until you practice it. And we only practice this once or twice a year, so nobody's very good at it. We did a video of the Oxford regional trainees on our training day, and they're all in the theatre with the consultants. We have model eyes, and we can do a phacoemulsification with the standard machine. You can then break the posterior capsule and do an anterior vitrectomy, and we inject egg white into the back of the eye, which is a vitreous substitute. You can stain it with triamcinolone, and everybody can have a go at doing the vitrectomy, setting up the machine, knowing what the parameters are. You can see that I'm actually being a bit selfish and hogging the limelight a little bit, but eventually I do get off the chair and other people sit down and have a go at practicing the vitrectomy. We use these model eyes that you can now purchase from Simulated Ocular Surgery website. I have no financial interest in this, but these model eyes you can do virtually anything with. You can take out cataracts, you can do squints, you can practice glaucoma surgery, and obviously phaco and anterior vitrectomy. So it's a very good way of practicing the skill before you actually come to do it on real life. So in summary, 2 preventative things, silicon-tipped IA and risk stratification, have been 2 things which have, as I say, my unit have reduced the incidence of posterior capsular rupture vitreous loss by 20%. And then on the management side, make sure you keep the anterior chamber stable. This business of inflating with a viscoelastic to keep the posterior chamber stable is important. Use triamcinolone, use a separate infusion and vitrector, and make sure you've got the vitrector set on cut IA and a maximum cut rate. And if you do all that, the results can be just as good as if it never happened at all. Thank you very much.
Dr. Namrata, you have probably the best educating system for the post-graduate.
Sharing my screen.